The next talk is from a good friend and colleague, Dr. Tiffany Kaza. Dr. Kaza received her MD and PhD from SUNY Upstate in Syracuse, New York, and then also stayed around and finished her pathology residency there before she came to Arkansas to do her nephropathology fellowship at Arcana Laboratories. I was lucky enough to work with her when she was an intern for the Nephrology Social Media Collective, for which she graduated in 2019. And now she serves on the executive committee and really wants to think about how nephrologists and pathologists can interact more often, and does that a lot on social media. So looking forward to her talk to expand membranous new antigens into lupus.
Thank you so much, Matt. I really appreciate the kind introduction. And the opportunity to present something that I'm really passionate about. Can you see my screen?
Yes.
Yep.
Okay. And so today I'm going to talk about membranous lupus nephritis. I have no conflicts of interest to disclose, and I work at Arcana Laboratories. I also am a fan of Neph Twitter, as Matt had described, so feel free to share if you'd like. So kidney involvement is very common in patients with systemic lupus erythematosus. 60% of lupus patients will develop nephritis at some point, and this is a disease burden of greater than 300,000 patients in the United States alone. And in lupus patients, some of them will present with acute kidney injury or nephrotic syndrome, or the disease can be subclinical and identified on a urinalysis where proteinuria or hematuria is identified. Overall, lupus is an autoimmune disease that flares and over time can lead to chronic kidney disease, and if under poor control, lead to even end-stage kidney disease, with 10% of patients that have membranous lupus nephritis and about 30% of those that have a concurrent proliferative component. So lupus nephritis can be one of the first manifestations of SLE, and it's very important to keep on our radar in any young woman who has a positive ANA and a membranous glomerulopathy on a biopsy. The SLE disease collaborating clinics criteria for lupus is a weighted classification system where 10 points are needed for a lupus diagnosis. And this is modified from the American College of Rheumatology criteria. But of note, in the renal domain, having a full house proliferative glomerulonephritis with a patient with a positive ANA gives you a full diagnosis. And for membranous glomerulopathy in a patient with a positive ANA, having one other feature would give you a diagnosis of lupus. And so something very important to keep on your radar, especially if renal manifestations are what occur first in the disease. And lupus is classified according to the International Society of Nephrology and Renal Pathology Society classification system, for which class 1 is a minimal mesangial lupus nephritis. So you have immune complex deposition without any significant proliferative changes. Class 2 is a mesangial proliferative, while class 3 or 4 is a focal or diffuse proliferative, in which there may be endocapillary hypercellularity, fibrinoid necrosis, crescents, destructive proliferative changes occurring within glomeruli. And class 5 is not a continuum of class 3 or class 4, but class 5 is membranous lupus nephritis. And about 15% of lupus nephritis is a pure membranous, but overall about 30% of those with a focal or diffuse lupus have a membranous component. So you're looking at about 40% of all lupus nephritis cases have a membranous component to it. So lupus is a very heterogeneous disease, but the findings in a biopsy can be pretty nonspecific. And so here's a PAS stain of a glomerulus showing some prominent capillary loops that have some formation of spikes and holes on silver stain, which would look like any primary membranous. There is global granular capillary loop staining for IgG, as you would expect in a membranous. And so here are some clues that might help distinguish a membranous lupus nephritis from a primary membranous glomerulopathy. Expressing other immunoglobulin heavy chains, so not just IgG, but either IgA, IgM, or both. And expression of C1q it could be increased in membranous lupus nephritis versus membranous glomerulopathy. Typically, primary membranous stains for IgG, C3, kappa and lambda light chains, and so having other heavy chains or C1q could indicate an autoimmune etiology. Additionally, there may be what we call tissue ANA staining, and so you have the tubular epithelial cells and sometimes also within podocytes, the nuclei staining for IgG. Having extraglomerular staining is seen in autoimmune diseases, including membranous lupus nephritis. So having tubular basement membrane deposits or vascular deposits would lead you toward an autoimmune etiology. And here's electron microscopy showing some electron dense deposits. Mesangial immune deposits are very common in membranous lupus nephritis and occur in about 70 to 80% of cases. And in primary membranous, occasionally you do have mesangial, but it's more commonly restricted to subepithelial and intramembranous components. So the presence of mesangial immune deposits and particularly subendothelial deposits, although less common, about 15% of cases, could indicate an autoimmune etiology. And finally, tubular reticular inclusions. So tubular reticular inclusions, this is at the subendothelial surface, and they serve as interferon footprints. And lupus is an interferon-driven state, as well as systemic viral infections can as well, such as HIV or SARS-CoV-2 infection also could cause tubular reticular inclusions. Additionally, for IgG subclasses, as Dr. Beck and Dr. Alberati were discussing, predominantly have IgG4 in primary membranous, where you have IgG1 that then class switches to IgG4. In membranous lupus nephritis, expression of all subclasses or multiple subclasses is common, and IgG4 predominance is not common. And so this is a study from Columbia University, and they looked at these features that we just described, having full house or C1q staining, extraglomerular staining, subendothelial staining, or tubular reticular inclusions. And when you have all of these findings, it has very high specificity for membranous lupus nephritis, 99%. But even having 2 or 3 of these features gives you a quite high specificity for lupus. So unlike in primary membranous, where the majority of the antigenic targets are unknown, so I guess 16%, as Dr. Alberati was saying, in membranous lupus nephritis, we only have a couple known autoantigens right now. PLA2R, while being the most common in primary membranous, is quite rare in the setting of membranous lupus nephritis, occurs in about 3% of patients compared to maybe 70% in primary membranous. So the first described autoantigen was from Dr. Sethi's group at the Mayo Clinic, and they described exostocin 1,2 complex involved in membranous glomerulopathy. This discovery was through laser capture microdissection to enrich for glomerular proteins, followed by mass spectrometry that identified EXT1 and EXT2 as an antigenic target. This glycosyl transferase is required for the proteins to act together for its catalytic function, so you don't typically see one without the other. And in staining of biopsy cases that were predicted to be positive by mass spectrometry, there's appropriate granular capillary loop pattern staining that you would expect in a membranous and not seen in control cases. So EXT1 and EXT2 were found to co-localize with immunoglobulin within the glomerular subepithelial deposits. And so here's IgG and EXT1 and an overlay image to show co-localization along the glomerular capillary loops. This was not seen in PLA2R, THSC7A membranous. And EXT2 has the exact same pattern of staining. So EXT1 and EXT2 positive membranous patients most commonly are patients with an autoimmune history. So if you look at all cases of membranous glomerulopathy that are EXT positive, 79% have lupus. Others may have other autoimmune manifestations as well. So those that have a positive ANA are even higher. And the mean age is younger than patients with idiopathic or primary membranous, and a majority of patients are female, as we would expect in enrichment in lupus patients. So as performed for PLA2R, THSD7A, or HTRA1 from the earlier talks, unfortunately, patient sera from EXT1 and EXT2 positive patients failed to react with EXT1 or EXT2 recombinant proteins. And so Western blots were performed using patient serum as a primary antibody, followed by anti-human immunoglobulin for detection. And under native conditions, reducing conditions, non-reducing conditions, there was a lack of antibody detection. However, it's still very important to stain for EXT, and this study will tell us why. So in the Mayo Clinic's cohort, they had 1/3 of patients with membranous lupus nephritis having EXT1 or EXT2 positivity. And they compared those that were EXT positive versus EXT negative in a 10-year retrospective look back to look at prognostic differences. And they also included those that had a concurrent proliferative component. So 25% of patients with EXT positive lupus had a concurrent class 3 or class 4. And remarkably, patients who are EXT 1-2 positive lacked any progression to end-stage kidney disease at a whole 10 years follow-up, compared to patients that had EXT negative membranous lupus nephritis. Even patients that at the time of biopsy had a proliferative component also failed to progress, which I thought was particularly striking. So staining membranous lupus nephritis cases with EXT1 or EXT2 is important because it can inform prognosis. And hopefully in the future, we'll have a way to monitor them. The next antigen I'd like to discuss is neural cell adhesion molecule 1. And our lab was involved with the discovery of NCAM1 through doing immune complex elution from the frozen kidney biopsy tissue, followed by mass spectrometry. And this was in a collaboration with Dr. Arthur's lab at UAMS. And the residual frozen tissue, we made protein lysates and then exposed those to protein G to pull out immunoglobulin from the biopsy sample. And then the immune complexes were then interrogated by mass spec. And mass spectrometry identified NCAM1 within a subset of biopsies. And so on a volcano plot, we have a low p-value and a high fold change here in the upper right corner, and have NCAM1 uniquely identified. And we did this in parallel to laser capture microdissection to enrich for glomerular proteins as well as done for the EXT discovery by the group at Mayo. And there are always more peptides here, but the protein G immunoprecipitation only includes those proteins that bind IgG. But these include more proteins that are enriched in a glomerulus, but showed the same peptides. So NCAM1 is an immunoglobulin superfamily cell surface glycoprotein. It has negative regulation of the expansion of T cells and dendritic cells, and it's expressed in podocytes as well as in the central nervous system. NCAM1 was found to co-localize with IgG in a nice granular capillary loop pattern, as we would expect in membranous without significant staining of PLA2R associated membranous. And NCAM1 associated membranous lupus nephritis occurred with or without a proliferative component. And so some cases had fibrinoid necrosis or endocapillary hypercellularity or crescent formation in addition to the membranous component. Overall, of 20 patients, 18 of them had a history of lupus. The other 2 all had a positive ANA, an underlying autoimmune disease. So we think that this is heavily enriched in autoimmune disease and in lupus. And the frequency overall from staining 6 months of consecutive membranous lupus nephritis cases, which involved 222 biopsies, we had 6.6% were NCAM1 positive. NCAM1 associated membranous affect predominantly females, and of a mean age of 34 years. They frequently had nephrotic syndrome, and 40% had neuropsychiatric manifestations. While we only have an N of 20 in this study set, it's difficult to determine whether this is actually enriched in neuropsychiatric lupus, with 9% of lupus patients overall have neuropsychiatric manifestations. So further investigation is necessary. I'm bringing this up because it is expressed in the central nervous system. It's been described to be overexpressed in reactive astrocytes following stroke and in the CSF of epileptic patients. So there could be a link with NCAM1, but further study is definitely warranted here. So antibodies were detected against NCAM1 in patient serum. And so we use the NCAM1 recombinant protein in patient serum as a primary antibody, followed by anti-human IgG, and have an appropriate band of the same molecular weight as the primary antibody. And we did not see any significant staining in membranous controls. Additionally, we did a cell-based indirect immunofluorescence assay. And so in this IFA, we took HEK293 cells and transfected them to overexpress NCAM1, used the patient's serum as a primary antibody, followed by addition to anti-human IgG. So if the patient's antibodies reacted with NCAM1 overexpressed within the cells, we should see fluorescence from fluorescein labeling of the anti-human IgG. And that's what we found. So this is HEK293 cells overexpressing NCAM with appropriate expression for the primary antibody. We have reactivity from patient sera and not from control sera. And I'd like to bring up a new antigen today. And so this is TGF-br3 associated membranous nephropathy, or transforming growth factor beta 3 receptor membranous nephropathy. We utilize protein G immunoprecipitation as well as laser capture microdissection, similar to with NCAM, and was found in a subset of membranous biopsies. There were peptides for TGF-br3 uniquely present by both within eluded immune complexes and through enrichment of glomeruli through laser capture microdissection. And TGF-br3 stained in an appropriate granular capillary loop pattern, as we would expect in a membranous glomerulopathy. These deposits tend to be very chunky. Sometimes they actually look hump-like you would see in an infection, although this is maybe the more typical pattern where they're large but aren't mistaken for infectious humps. And TGF-br3 colocalizes with IgG within glomeruli and did not colocalize with PLA2R-EXT cases. And unlike forms of primary membranous, TGF-br3 lacked IgG4 predominance, mostly expressed IgG1, 2, and 3. Some had all 4 subclasses staining. And approximately half of TGF-br3 associated membranous lupus nephritis biopsies had a proliferative component, which was a little bit higher than for EXT, but EXT, NCAM1, and TGF-br3 could all be associated with not only a class 5 lupus, but a class 3 or class 4 as well. And TGF-br3 patients, as well as patients with EXT or NCAM, were of a younger age than patients with idiopathic membranous. The frequency found from staining of a consecutive case series of 6 months of biopsies was 5.5%. And so to recap, EXT is the most common, about 32%. NCAM was 7%, and TGF-br3 is 5.5% of biopsies. And this was work from the help of Dr. Beck. And we were having difficulty detecting autoantibodies in patient sera against TGF-br3, and had tried reacting against a recombinant protein under reducing conditions, non-reducing conditions, native conditions, with and without with deglycosylation, and did not have any luck. And so Dr. Beck graciously tried human glomerular extract immunoprecipitation, and TGFBR3 was identified in the human glomerular extract. So the protein's there, but it did not immunoprecipitate with serum. And as a control for this experiment, in PLA2R positive cases had nice strong immunoprecipitation with PLA2R. So we failed to immunoprecipitate TGFBR3. In trying a cell-based IFA, when TGFBR3 is overexpressed in the 293 cells, we do not have any seroreactivity, and here's 3 different patients, and no signal was achieved. So there could be multiple potential challenges with detecting circulating antibodies. They could be formed within multimolecular immune complexes. Glycosylation or other post-translational modifications of the target proteins could disturb antibody binding. These could be opsonized by complement and again be large complexes. You could have a low avidity interaction. And the enriched proteins alternatively may serve as biomarkers but not be true autoantigens. I know this is being described for EXT as we're still looking for potential antibodies in patient sera. And although we believe that all of these are antigens, being an antigen would require that it has a corresponding antibody bound to it. And occasionally one limitation of mass spectrometry is that there are some proteins that don't fly as well. And having concurrent techniques leading you to the same target, I think does provide confidence. However, there still remains a possibility that these may only be biomarkers. So some take-home messages are that membranous lupus nephritis is a leading cause of nephrotic syndrome in patients with lupus, that you should keep membranous lupus nephritis high in your radar in a patient with membranous glomerulopathy that's a young female, and that we have new biomarkers that might have significance for prognosis, particularly EXT seems to have a great prognosis. Treatment monitoring. None of these yet have antigenic tests available, but the ability to detect NCAM1 antibodies may lead to antibody testing similar to PLA2R, THSD7A in the future. Searching for an underlying autoimmune disease would be implicated if a biopsy was found to express any one of these antigens, as all of them are enriched in patients with autoimmune disease. And defining antigenic subtypes could in the future potentially lead to differential treatment and outcomes as we learn more about it. And so I would like to thank all of those involved in the work. Some of this work I was describing was that of the earlier discoveries from the Mayo Clinic, but we've also been lucky to participate in a large collaboration from investigators from Arcana, UAMS, as well as Dr. Beck and Dr. Alberati. So it's fun to be in the session with them here. And I'd like to really thank you for your kind attention as well. And I'd be happy to answer any questions. If anyone has any ideas for seroreactivity, please shoot them my way. I want to hear any and all of them. And thank you so much, guys.